broadcast is now starting. All attendees are in listen-only mode.
Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders. I will be your organizer for this evening and would like to welcome you to our webinar on how anxiety and repetitive behaviors interact to complicate a child's life. Thank you all for joining us. Before I have my colleague introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. You may send questions during the webinar. However, we will have Dr. Roberts answer the questions at the end of her presentation. We will get to as many queries as time allows, and in addition, tonight's presenter is available to take your questions on the Wednesday webinar blog, which is accessed from our homepage under the heading Programs. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed part of the presentation or would like to watch it again, we will send you a link in approximately a day it will be posted to our website. We value your input, and in order to expand the webinar experience in the future, we need everyone to fill the survey out when you exit the webinar. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thanks, Kelly. Good evening, everyone, and welcome to tonight's webinar on repetitive behaviors. Before I introduce our presenter, I would like to take a moment to remind you about a couple of upcoming events in our calendar. We still have a few spaces available for our family retreat weekend on June opportunities for families living with TS to be able to meet other families trying to do exactly the same thing. Not only is it our biggest annual support group and family networking event, it has also been called the best weekend of the year by one of our families. I strongly encourage you to register today. You won't regret it. Secondly, our next Ask the Greats is scheduled for May 24th from 7 to 8 p.m. Eastern. Ask the Greats, that's spelled with a capital TS, and goalkeeper Tim Howard, a New Jersey native diagnosed with TS at age 10. It's designed to empower individuals with TS, especially kids and young adults, to develop the confidence, leadership, and self-advocacy skills necessary to overcome their challenges. This next live chat is with 4 young advocacy leaders in the TS community. They'll be discussing and taking attendee questions on the topic of the evening, which is navigating social interactions. The recommended age for attendees is 13 to 20, and registration can be found on our website. Now to the introduction of tonight's presenter, Dr. Kathryn Roberts. Dr. Roberts received her bachelor's degree from the College of William and Mary and her doctorate in clinical psychology from the University of Delaware. She completed her clinical internship at Massachusetts General Hospital, Harvard Medical School. Dr. Roberts is a postdoctoral fellow at the University of Pennsylvania's Child and Adolescent OCD, Tic, Trich, and Anxiety Group, also known as COTTAGE, where she specializes in the assessment and treatment of child anxiety with related repetitive behaviors, with a particular interest in the mechanisms that underlie the co-occurrence of such presentations. She's performed EEG and MRI research to better understand the neural correlates associated with these presentations. Dr. Roberts has presented her research at professional conferences and has been published in journals like Psychophysiology and biological psychology. Dr. Roberts, welcome to our Wednesday webinar lineup. And now, without further introduction, I'm pleased to turn tonight's webinar over to you.
Thank you for that introduction, Marty, and hi, everyone. I'm excited to be joining you guys today for the Wednesday webinar series. I first want to promise you that despite the spools of thread that you see on the title page here, you are in the right place. I would be an absolutely awful person to talk to you about sewing for a webinar. But instead, I'm using this image because I want to talk to you about some of the common threads or common features that cut across diagnostic categories related to anxiety and anxiety-related repetitive behaviors. I'm going to come back and define specifically what disorders I'm referring to shortly, but I want to step back with you first and think big picture about why this topic is relevant and also for whom this topic is relevant. First, if you're a parent of someone who's been given multiple diagnoses, you may have felt overwhelmed when you were first informed that your child met criteria for multiple disorders. Maybe you had already recognized that there was a lot going on for your child, or maybe their sheer quantity of diagnoses was overwhelming at the time of the evaluation. As a clinician who conducts evaluation and frequently has patients meet criteria for more than one diagnosis at a time, the family's emotions in the room have been palpable to me. And so for those parents today, I want to help you understand why multiple diagnoses in the area of anxiety and anxiety-related repetitive behaviors are relatively common. And it doesn't feel as overwhelming to clinicians who are knowledgeable about these disorders because a number of them are not really all so different from each other. Second, if you're a parent, educator, or clinician, your child or student or patient might not have a clear diagnostic picture. For example, maybe the child has a number of fears that seem to sporadically change over time. Some fears like bugs might trigger avoidance, where other fears like safety might trigger checking behaviors. So for clinicians, it might be hard to disentangle what's anxiety from what's OCD diagnostically. And for parents and educators, it might be hard to decipher how to help the child when their reactions to fears are so different. Therefore, we want to address in this presentation some of the key principles to treatment that cut across these disorders and discuss how they can be applied flexibly depending on the combination of symptoms. Third, research is still emerging about some disorders like autism, which is characterized in part by repetitive behaviors and also has a high rate of co-occurring anxiety. So what are some of the common threads from what we know about other repetitive behaviors that cut across into autism, and how can we use what we know about effective treatments for these other repetitive behavior disorders that can inform treatment for autism? As you can see from the last slide, the goal of this talk is to simplify how we think about disorders that are characterized by anxiety-related repetitive behaviors by identifying commonalities across them. Of course, I have to add in a disclaimer here. I do want to be clear from the beginning that despite the goal of this presentation being to simplify thinking about these disorders, there are complexities to them and treatment should be overseen by a medical professional. The quick overview of today's webinar is that I'm first going to introduce the domain of anxiety-related repetitive behaviors, and then we'll discuss commonalities in these disorders. First, diagnostically, and in doing so, I want to introduce you to the direction that clinical research in the field is moving, which is to think about repetitive behaviors less as falling into categories and more to identify common brain areas and brain circuits that aren't functioning typically across multiple repetitive behaviors. Second, we will look at the commonalities in terms of reinforcements of the repetitive behaviors. So what keeps these behaviors coming back in a repetitive fashion? And we'll also consider similarities in terms of evidence-based treatment approaches. Finally, I want to dive into why it's helpful to understand these commonalities in terms of supporting kids suffering from one or more of these disorders. So let's start by looking at the domain of anxiety-related repetitive behaviors. Repetitive behaviors are actually considered to be adaptive in youngsters in the early stages of development. Young ones can often become preoccupied with lining objects up or ordering objects and stacking blocks. They often attach themselves to one object like a blanket or a stuffed animal that they carry around. They enjoy repetitive games like peekaboo. And they can also hone in on details of something with such great focus that you or I might not have the same appreciation of. And of course, they find comfort in routines as well. So it's believed that these repetitive behaviors in the early years function to decrease a child's anxiety and also help them organize and accommodate new information as they're learning about their environment. But what's interesting is there are remarkable similarities between these early adaptive repetitive behaviors and those that cause interference in clinical disorders in later years. In clinical disorders, anxiety-related repetitive behaviors are characterized by four main features. The first is repetition, which involves doing something over and over again. The second is rigidity, which means needing to do something a certain way, or else it won't feel just right, or else something bad could happen. This really speaks to the rules by which behaviors must be carried out. Third, and following closely from rigidity, is invariance. I describe this to patients and parents using an oak tree and a willow tree analogy. Oak trees are very strong and sturdy, and they're set in their ways, and they're not going anywhere, and there are many good features to the determination associated with this. However, when a big wind gust comes, the oak tree might have a branch that breaks off, and this could be analogous to a tantrum that we see in a kid. So instead, we want to help our kids be able to adapt and be mentally flexible when they need to be, like a willow tree where they can bend with the wind, but they stay intact. So this isn't asking kids to change their opinions on something. They might still prefer something to be a certain way. Like maybe a child likes to sharpen their pencils before they leave for school every morning. But if the bus is coming down the street, we would want them to be able to be flexible and wait until school to sharpen their pencils that day. The fourth feature is inappropriateness, which considers the way that the behavior is interfering in the person's life. If we go back to the pencil example, for instance, sharpened pencils are useful for school, so sharpening them is a behavior that seems adaptive. However, if the child is inflexible about needing to sharpen them at home, they might miss the bus, and they might subsequently inconvenience mom and be late to school. And this is where a seemingly adaptive behavior becomes inflexible and starts to interfere with the person's life, and therefore becomes inappropriate. I also want to make clear what I mean by the term anxiety-related when discussing repetitive behaviors. Briefly, repetitive behaviors in this cluster can be triggered by anxiety. That's not in every case, but we see it frequently enough to group them together. So as you can see, we're already starting to think about some of the common threads. We also see higher rates of co-occurring anxiety disorders with these repetitive behaviors. I want to look together at some of the diagnoses where we see anxiety-related repetitive behaviors in our diagnostic manual. As you can see here, repetitive behaviors are seen across multiple diagnoses. And not only that, but across multiple categories of diagnoses in our diagnostic manual. To briefly introduce the repetitive behaviors associated with these disorders, tic disorders involve quick and seemingly irresistible vocalizations or motor movements. Autism spectrum disorders are diagnosed by the combination of social deficits and also repetitive behaviors. And these repetitive behaviors can include repetitive movements, such as hand flapping, or we see finger flicking, repetitive use of objects like lining up toys or spinning coins, repetitive speech, which we might see through stereotyped words or phrases, and also inflexibility around a certain fixed interest. Excoriation disorder refers to repetitive skin picking. Pathological gambling disorder is likely self-explanatory and involves the excessive risking of possessions. Obsessive compulsive disorder is diagnosed when a person experiences recurrent intrusive thoughts or feelings that are neutralized by an associated response. Trichotillomania involves repetitive hair pulling. And I've also included several examples of anxiety disorders because anxiety disorders as an area are associated with recurrent intrusive fears or worries and often repetitive avoidance to the distressing thought or situation. So why do we fit a person's symptoms in a category or diagnosis in the first place? As clinicians, when a new client walks through the door, our job is to conduct an assessment by gathering information about that individual's unique constellation of symptoms and mapping them as best as we can onto disorders that are already spelled out in our diagnostic manual called the DSM. And the DSM lays out diagnoses according to clusters of commonly co-occurring symptoms. So maybe the person has a few extra symptoms that don't clearly fit into a diagnostic category, or maybe the interference of their symptoms is lower such that they don't meet criteria for that diagnosis. So the diagnoses are not perfectly precise to explain what an individual is dealing with, but they do allow clinicians and also families to begin working towards a treatment that's been found to be effective for many people with that diagnosis. That being said, there are several limitations to our current diagnostic manual that are driving researchers to consider a different approach to thinking about psychological disorders. And I'm going to walk you through a few of these limitations using anxiety and related repetitive behaviors, not because I care about you knowing the limitations themselves, but because if we consider the limitations that are imposed by categorizing people by their symptoms, it puts forth this idea that maybe the groups of anxiety-related repetitive behavior symptoms that we see in our kids aren't quite as distinct from each other as they feel when we categorize them categorically. The first is creation, and by that I mean the definition of the disorders themselves. Diagnoses and the criteria that have to be met in order to qualify for a given diagnosis are created based on clusters of commonly observed behavioral symptoms, which have been informed by research and clinical work. But currently, in psychology, unlike in the medical model, there isn't a test for anxiety like there is for strep or the flu. So although our diagnostic categories are based in evidence, there's a certain subjectivity to the categories that we have in place currently. In this, it also means that we aren't necessarily capturing the root of what's going on or the brain-based mechanism of what's underlying the symptoms that we're seeing. We're only assessing the ways that they're behaviorally interfering. In other words, we're not looking to see if there are brain-based difficulties with control over stopping motor responses for Tourette's, but rather we're defining Tourette's by the number of vocal and motor tics seen. And similarly, we're not defining anxiety by a heightened neural or brain reaction to threats, but rather by the types of worries or fears that are manifesting for the person. Second, we see excessive comorbidity among these disorders. And I pulled two diagnoses for patients that are currently on my caseload right now, and I think they do a beautiful job of illustrating the increased likelihood for co-occurring anxiety-related repetitive behaviors. And by this, I mean that if someone has one disorder of an anxiety or anxiety-related repetitive behavior, the likelihood that they will meet criteria for a second disorder in this area far exceeds chance. And I could give you a lot of stats on this, but to drive my point home a little bit further, I'll give you two. First of all, about 20% of the normal population has an anxiety disorder, but in individuals that have trichotillomania, meaning that they pull their hair out, 60% have a co-occurring anxiety disorder. In individuals with autism spectrum disorder, 20% have a tic disorder relative to only 1 to 2% in the normal population. Third, we see overlapping symptoms and phenomenology that can present similarly during an evaluation, and I'll give you a few examples to demonstrate this. One is with OCD compared to other anxiety disorders, and particularly generalized anxiety disorder. Both generalized anxiety disorder and OCD include intrusive thoughts that are distressing to the individual, and they may be of similar content as well. So the diagnostic interviews for OCD and generalized anxiety disorder actually ask about some of the same content areas, including safety, illness, and perfectionism. In addition, the intrusive thoughts for both disorders can cover multiple content areas at once, meaning they could fear or have intrusive thoughts about different content areas within the same day. And the content areas can both change across time as well. So these presentations are similar in a number of ways, which begs the question of how we get a diagnosis of either OCD or GAD. One way that we differentiate the two is the reaction to that uncomfortable thought. Distress from OCD thoughts is followed by a behavior that neutralizes the thought. And these are called compulsions and can include something like hand washing to eliminate fear of contracting an illness. With anxiety, we typically see avoidance in response to that uncomfortable thought, like avoiding social situations if you fear that others will negatively evaluate you, or avoiding flying if you have a phobia of planes. However, it's not always that clearly defined. Individuals with vomit phobia, which is a kind of anxiety disorder, might wash their hands excessively, just like someone with contamination OCD might. With generalized anxiety disorder too, in addition to avoiding, we also sometimes see a response of rumination where they can't disengage from the worry thoughts, but they're also not doing an action to actively get rid of the thoughts like in OCD. A second consideration is the extent of engagement in the repetitive behavior in a given episode. So if checking something, if they're fearing safety, do they just check once to calm their fear, which is more like generalized anxiety, or might they repeatedly engage in the checking behavior over and over again in a single episode, which makes it seem more like obsessive compulsive disorder? One example where the lines are particularly muddied is perfectionism. Perfectionism itself isn't a diagnosis, but instead can be subsumed within generalized anxiety disorder or OCD. And perfectionism is associated with discomfort of failing by self-imposed standards, of making mistakes, and of tolerating things not being just right. So maybe how stuffed animals are placed on the bed or how a sentence is constructed. Sometimes these not just right feelings are followed by clear compulsions like erasing and rewriting things to make them perfect, or fixing the positions of stuffed animals to make them feel better. Oops. Bring this back up for you. And I included a picture of shoes up here because something as simple as putting shoes away can become very distressing for a kiddo with perfectionism who might lie in bed at night distressed that his shoes aren't positioned exactly right beside each other, or that the shoelaces might not be tucked perfectly into the shoe. And this can be so distressing that they engage in the compulsion of getting out of bed routinely to make sure that the shoes are positioned just as they want. So these behaviors associated with perfectionism may be described best as OCD because they're clear compulsions. However, what if the person is someone who just doesn't like to be late and gets uncomfortable in the process of making sure that he's always on time, or someone who strives to do well on assignments and takes a lot of time to consider alternatives for writing something before moving ahead? So there aren't as clear of compulsions associated with these, but the person is still considered perfectionistic. A second example is the domain of body-focused repetitive behaviors, meaning that the repetitive behaviors hurt or damage oneself. These include tic disorders, skin picking, and hair pulling. Picking and pulling are considered particularly similar to each other in that even though the outcome is interfering, individuals find the acts of picking and pulling to be somewhat pleasurable. In contrast, tics are described to be unpleasurable. The behaviors associated with tics, picking, and pulling are different from each other, but all of these disorders are preceded by physical urges and followed by a feeling of relief in which the physical urge disappears. Sometimes, though, individuals do report cognitive urges, like a hair doesn't feel just right or a blemish doesn't look just right. And with tic disorders, we sometimes hear, well, I just have to do this motor movement without a known physical urge that they're aware of. So this is where it begins to blend with OCD and leads us to the concept of Tourettic OCD. Just like there are different flavors of ice cream, there are two different flavors of obsessions in OCD. One flavor is that the intrusive thoughts are a fear of something bad happening, maybe a fear of getting sick, or a fear of harm coming to the family, or a fear of harming their relationship with God. These fears can cause individuals to engage in a behavior that alleviates the discomfort. So maybe they wash their hands excessively so that they don't get sick, or they check on their family members' safety over and over, or they pray excessively to make sure they maintain a good relationship with God. The other flavor of OCD is informally considered to be Tourettic OCD. This is what you see in pink here. And this is a flavor of obsessions in which people experience general discomfort in their bodies that cause them to engage in their behavior repetitively. Some people have described this to me as being centralized to a certain area of their body, like in their hands or in their eyes, but more often I hear that it's centralized to their mind or in their head. And others describe it to me as being spread throughout their body. Regardless, they aren't responding to a fear of something bad happening, but instead they're responding to discomfort in their body. And this causes them to engage in behaviors that alleviate that discomfort. It's considered Tourettic because the urge doesn't seem entirely cognitive, but somewhat has a physical element to it. One example of this kind of OCD is where someone feels the need for things to be lined up just so. Let's say someone sits down to do homework in their room, but notices that things aren't arranged on the desk just as they would like. They don't fear anything bad happening if they don't fix the item's placements right away, but instead they feel a general discomfort throughout their body, which importantly, I would say, is often accompanied by the belief that they won't be able to get through their homework or get through whatever it is that they're doing until they fix the items on their desk. Where the lines between OCD and tics get particularly confusing is when the obsession is that general, not just right feeling of discomfort, and the compulsion involves a motor movement without a known purpose, maybe flailing the arms or touching something symmetrically. With tics, we most often see physical urges precede the motor movements. However, there are times that a person's insight is limited about what comes before an urge. And we particularly see this with younger kids who just have a limited ability to decipher if there is a physical urge at all. And so it can be particularly challenging to differentiate the tics from the OCD at these times. A fourth similarity that we see among anxiety and related repetitive behaviors is that similar brain areas and circuits are implicated, which is important to mention but is also beyond the scope of this talk. Now, I will warn you that this gets a little bit technical, but we found it important to include and share with you. So I'm going to go through this hopefully a little slowly to make sure you understand it, but feel free to ask questions at the end as well. So because there are issues with these high rates of co-occurrence and disorders, overlapping symptoms, and overlapping biological bases of behavior, and in order to approach research on mental illness from a perspective that can more directly inform the most effective treatment approaches, the National Institute of Mental Health, or NIMH, has put forth a new way of thinking about mental illness. And I want to introduce you briefly to this initiative, which is called Research Domain Criteria, because it addresses some of the limitations with our current diagnostic system and gives us a different way to think about repetitive behaviors. I will note that it's not intended to be a new diagnostic system, but rather to change our approach to thinking about groups of symptoms that we see and to directly inform the treatments that we use for these symptoms. In this research domain criteria initiative to thinking about mental illness, NIMH is considering each individual's psychological presentation, meaning each of their strengths and weaknesses, on a continuum rather than fitting into diagnostic categories. The way they're working toward this approach is by studying many domains of mental functioning. To orient you to the visual here, the large headings for the domains of functioning are seen on the left side of the table. And I don't want you to get caught up in the category names like negative valence systems. Instead, I want you to understand that some of the domains of functioning are relevant to repetitive behaviors. And these include performance monitoring, which means monitoring your behaviors, inhibitory control, or mentally controlling, stopping yourself from doing something, and motor inhibition, or mentally controlling, stopping your motor actions. So they first want to study each of these dimensions of functioning in healthy individuals, and they want to do so across multiple units of analysis, meaning from genes and biology all the way up to behaviors and even perceptions of behaviors like in self-report questionnaires that you may have filled out. And you see each of these methods or units of analysis shown across the top of the chart there. So really what they're trying to do is to compile research that's already being done to fill in this huge table. And the link to the table itself was on the last slide if you want to look at it. Once they've come to understand the functioning in healthy individuals, they then want to look at variations of mental difficulties. And that way, mental difficulties can be considered in terms of disruptions to the normal systems or functioning. Again, this research domain criteria approach means thinking about groups of symptoms like tics or hair pulling not as distinct categories, but rather placing them along continua for given domains of functioning, like performance monitoring, where it ranges from typical to atypical. So for instance, if researchers see that performance monitoring, or again, monitoring your behaviors, is atypical at the brain level for a person, they can then look to a different unit of analysis, maybe behaviors, to see if atypical performance monitoring at the brain level is repeatedly associated with a certain repetitive behavior. In addition, researchers can start to compare different presentations or sets of behavioral symptoms to see if there are any common threads in associated brain-based functioning. And they can begin to ask questions about if there are common mechanisms or threads that are consistently atypical across various repetitive behaviors. So I'll spell this out on this slide. So one thing that they're curious about is if one area of dysfunction in the brain, like one thread, could lead to more than one behavioral symptom that we observe. So in other words, is a thread like atypical motor inhibition at the brain level common to what we see behaviorally as OCD and tics? Of course, compiling research to fill this table for healthy individuals, let alone the many variations of mental illness, is going to take time, and the field is still working to get there. But it's an important direction for several reasons. First, it may explain why there is greater likelihood of multiple diagnoses, overlapping symptoms, and also common brain areas involved. It also puts forth that there may be one or two common brain-based threads or mechanisms that might account for more behaviors, just as I described on the last slide. And this allows us to think about treatment modules that might be effective for targeting these common areas of functioning rather than just addressing the symptoms that we see manifesting right now. This is also important because it's shifting us away from a categorical model of thinking, so working to reduce some of the stigma that's associated with mental health. So it's not placing you in a bucket of having a disorder or not, but rather considers each symptom along a spectrum, and we certainly all have strengths and weaknesses. In the end, as we say in our clinic, the brain doesn't recognize or care about diagnostic categories. That's the insurance companies that care. So it's important to consider these common diagnostic features in individuals with these symptoms to make sure that we're treating them the most effectively. Now that we've discussed the direction of the field in terms of considering common threads that cut across diagnosing different repetitive behaviors, I want to think about common threads in what keeps these behaviors coming back in a repetitive manner. Let's look at anxiety first. With anxiety, individuals experience anxious thoughts. I'll take the classic example of a dog phobia, which I like to use with kids because many of them know someone who's afraid of dogs, and if not a dog, a spider. So if someone sees a dog, that's a trigger for them, and they experience an intrusive, anxious thought that the dog is going to hurt them. So naturally, they feel distressed. If your brain automatically says that the dog is going to hurt you, and you experience a physiological fear response, who wouldn't want to get out of that situation? Avoidance provides temporary relief in that situation, and they're safe from the dog. And it's this relief, though, that keeps the cycle negatively reinforced. So the person's going to keep avoiding dogs because avoiding them takes away the distressing fear. The OCD cycle is so similar. We can replace the term anxious thought with obsession, and we can replace the term avoidance with compulsion. What's key about this cycle is that obsessions need not just be thoughts. They can also be feelings. One example of this is someone who experiences an intrusive feeling of disgust around a sibling. This feeling causes them to feel uncomfortable, so they engage in a behavior or a compulsion that gives them temporary relief. So maybe they lean away from the sibling, or even more subtly, maybe they actively move their attention somewhere else. And it's that relief that is so powerful that the next time they're around their sibling and experience that disgust feeling, they're going to engage in similar behaviors even more quickly. And eventually, it will become natural for them to engage in these behaviors such that they might not even have awareness after a while of the subtle ways that they're avoiding that feeling. Each compulsion, though, even if they're not aware of it, is fueling the fire that intensifies the strength and frequency of those obsessions. In this case, the disgust reaction towards the sibling. So how does this apply to body-focused repetitive behaviors? Rather than thoughts, they're triggering situations. This could be negative emotions like anxiety or sadness. It could be boredom. With tics, we also hear tiredness as a common trigger. And these increase feelings of discomfort. Recall that urges in body-focused repetitive behaviors are often physical. They are often described as an itch or tension. For tics, they can be, they're often at the site of the tic itself, but for picking and pulling, they can be on the hands or at the site of picking and pulling. Sometimes, though, as we discussed earlier, urges can blend into the cognitive realm. So with pulling, an individual might feel a hair that doesn't feel just right, or they might even see someone else's hair that isn't just right. And both of these move their attention to their own hair, which builds the strength of the urge to pull. In response to these physical and cognitive feelings of discomfort, individuals engage in the behavior, picking, pulling, or tics, just like the other models that provide temporary discomfort in that the urge subsides. But as soon as the urge returns again, we're back to the same repetitive behavior because that relief is so powerful. This is a graphic representation that shows a little bit more in depth how the avoidance of discomfort is reinforced. And it's relevant to distressing thoughts, feelings, and urges across each of the repetitive behaviors that we just discussed. So for the sake of an example, let's consider OCD with a person with a contamination worry. So when the person is faced with that anxiety trigger, like a dirty sink, his anxiety about germs might begin to rise. And when that anxiety about germs becomes unbearable, that's when they avoid and engage in the compulsion. And that compulsion gives them immediate relief because it allows them to flee from that really uncomfortable feeling of the obsession. And that relief is immensely gratifying to get away from that feeling so quickly. This escape would be okay, except for the fact that the person doesn't wait long enough to find out if the situation is really as frightening and as insurmountable as they think it is. That causes the person to believe then that compulsions are the only way that they can get out of obsessions because they don't attempt any other ways to overcome them. And this belief is reinforced with each successful time they escape that uncomfortable feeling. So before long, anytime an obsession strikes, they're just making a beeline to the sink without even thinking about it. If we think about how this applies to tics, with Tourette's, the belief that forms is that discomfort will not go away unless we tic. I know Marty Franklin gave a great talk recently on Tourette disorder that I encourage you to listen to for more research on this. But in terms of avoidance, it boils down to the fact that we engage with the tic more quickly because we don't challenge the view that we can't tolerate the discomfort and that it won't naturally go down on its own. Taken together, the two common threads that we see across these disorders in terms of reinforcement cycles are first, difficulty tolerating discomfort, be it catastrophically fearful thoughts or intrusive feelings or physical urges. And this naturally lends to the tendency to avoid these discomforts. And so by avoidance, I'm not speaking only to situations, but I'm speaking more to avoidance of that feeling of discomfort, whatever it might be. We'll discuss these threads more as we move into the common features of treatment now. There has been a wealth of research investigating effective treatments for these various disorders. I've listed here treatments that are deemed to be evidence-based for anxiety, OCD, and our body-focused repetitive behaviors, but where I want to focus attention is on the key components of each treatment, or that third column. For anxiety disorders, awareness training involves understanding relationships among thoughts, feelings, and behaviors, helping individuals to recognize anxiety as it manifests for themselves. Cognitive restructuring helps to identify the thinking traps that the brain is getting stuck in and to challenge those thoughts. So maybe your child's automatic thought is that their parents are dead if they aren't home on time. And so we want to help them identify that that's a catastrophic thought. That's the worst possible outcome. And that can help them realize that it's anxiety and likely a false alarm instead of a true threat that the parents are dead. The last component of treatment for anxiety disorders is gradual exposure to fears. For OCD, after learning about the OCD cycle, the two key treatment elements are exposure and response prevention. Exposure is to the feelings of discomfort, so the germs at the sink or your sibling in my discussed example. And response prevention means resisting engaging in the compulsion, so running away from the sink or washing your hands or leaning away from your sibling. For trichotillomania, or hair pulling, and excoriation, or skin picking, the evidence-based treatment primarily used is habit reversal training. This first involves awareness training, or learning to recognize your own triggers and urges in the moment. Competing response training refers to doing something else to help you ride out the urge. And this does involve moving your attention away from the urge itself. Social support is also an important component because it helps to ensure that the techniques are implemented effectively and that triggers are managed. The treatment for tic disorders is comprehensive behavioral intervention for tics, which is considered to be HRT+. So it encompasses habit reversal training as described above to help manage internal urges. However, there's also a component of function-based intervention, which involves understanding the environmental or external components that may also be perpetuating the behavior. So I want to look together at some of the common threads across these treatments. First, awareness training is one of these threads. This involves awareness of each piece of the reinforcement cycle that I reviewed a few moments ago. And it boils down to how can we implement treatments and changes without awareness of what's going on naturally. So awareness of triggers allows us to take a couple approaches. First, we can work to decrease the triggers themselves. For instance, if a repetitive behavior is triggered by anxiety, we could work to decrease the anxiety, either through therapy and facing fears, or problem solving some of the stressors in the individual's environment. Second, we could also implement strategies to help prevent some of these behaviors, which I'll discuss more on the next slide. We also need awareness of the distressing thoughts and urges so that we can determine the points at which we need to lean into the anxiety. And there's strategies that can help us ride out these emotions too, which I'll present shortly. Third, we need to have understanding of when the behaviors are occurring so that we can catch ourselves and determine how we can approach rather than avoid that discomfort. Stimulus control is another common thread that's integrated into habit reversal training for body-focused repetitive behaviors. I call this prevent with my clients because this is what we do when in the triggering situation to prevent the behavior from happening. So if through increased self-awareness we've identified that watching TV is one time that pulling typically occurs, one strategy that can be taken is to engage in a behavior that prevents the action of pulling from happening, so a barrier in another sense. So this could be wearing gloves or sitting on your hands or putting a hat on each time you watch television. And it serves as a physical barrier, again, to prevent the action of pulling. What's key about stimulus control techniques, though, or these prevent methods, are that while they do prevent the behavior, they don't increase your ability to tolerate the urges. It's really just preventing the behavior from happening. The same concept can be applied with OCD as part of the response prevention component to treatment when we want to prevent a compulsion from happening. And this can be particularly useful when the strength of the urges is strong. So not only would a stimulus control or prevention method be helpful in decreasing interference that's caused by the compulsion if we're preventing the compulsion from happening, but it also keeps us from fueling the obsessions. Because remember, the more that we engage in a compulsion, the more we're fueling the obsessions to come back with more intensity and more frequency. At the same time, though, we also need to engage in exposures to help increase the ability to tolerate discomfort without engaging in the compulsion. Here's a brief example of how stimulus control, or this prevent method, is useful for repetitive behaviors apart from the intended body-focused repetitive behaviors. So here we have a teenage girl who has OCD because she experiences intrusive thoughts about social media and pop culture topics, and particularly those that have where people have differing opinions on them, such as the Aziz Ansari sexual misconduct allegations or the Me Too movement. She struggles to disengage from these thoughts, and the only relief that she can get is when she researches the topic more. And this can often occur for hours at a time, which prevents her from getting her schoolwork done. The researching provides her relief in two ways. First, it calms a not just right feeling because she knows, because she wants to know everything about the topic, and she feels not just right if she doesn't know all the information. And second, it gives her relief in that she finds opinions that are similar to her own, so that she doesn't feel like she has the dissonant view. What's particularly challenging is that she's motivated to fight OCD, and she resists engaging in the compulsions until the threshold of anxiety is reached. And at that point, she feels like she has no control and immediately gets on her electronic device to research. So while primarily exposure and response prevention is useful in treatment for her, Stimulus controller, this prevention technique, can be incorporated to keep her electronic devices away from her, and to basically serve as a stop sign, to give her pause to remember her motivations for not wanting to start researching. And as she gains increased tolerance of the discomfort through simultaneous exposures, we'd want to fade out the stimulus control, meaning we'd want to give her increasing access to her phone to allow her the chance to exert that control. Competing responses, or competes as I call them with the kids I work with, is another thread that is used in treatments for various repetitive behaviors. It's part of the habit reversal training protocol, and it's intended primarily for use with the body-focused repetitive behaviors. This is a technique that's implemented when the urges to pick or pull or tic arise, so when individuals experience that physical discomfort. And it really boils down to doing something else. Competing responses can either be physically incompatible, meaning that they involve the hands or another part of the body that is typically needed to engage in the repetitive behavior. So for someone who pulls, a competing response could be pulling on a koosh ball instead, or for someone who picks, maybe it's playing with silly putty. For someone who has a vocal tic, it might be taking a deep breath. Each of these behaviors is incompatible with the repetitive behavior itself, meaning that physically they can't occur at the same time, so it prevents the maladaptive repetitive behavior from occurring. Competing responses can also be physically compatible, meaning that the person would have access to engaging in picking or pulling or ticking, but instead they choose to put their attention elsewhere. So maybe they could press their foot into the floor and actively think about it, or they could engage their attention fully in a soccer game or on their homework. The act of moving your attention to something else is what research has shown really makes the competing response effective. The way in which competing responses are effective is shown here. Like I said earlier, competing responses are designed to be put in place once the urge begins, so that they can help the individual to ride the wave of that urge. So the urge will get stronger, but it will also naturally fade as the person tolerates the discomfort and also begins to move their attention elsewhere. Across many repetitions of implementing the competing response to prevent the tic or picking or pulling from occurring, we see that the strength of the urge often decreases, and with this, the frequency of the urge often decreases as well. I will say that we know that tics wax and wane, and so regardless of urge intensity and frequency, this method of exposure to discomfort, coupled with competing responses in place, increases the ability of individuals to tolerate the discomfort that's associated with these urges, so that it continues to not interfere with their functioning as much, even if the urges arise. This concept is very similar to exposures for anxiety and obsessions, where individuals confront their fears and discomforts. When they face their fear and sit with that discomfort, be it sitting in the same room as a dog if they're a dog phobic, or touching the doorknob and refraining from hand washing if they're dealing with contamination obsessions, they don't get the immediate relief of avoiding, but slowly the discomfort does fade. And with each successive exposure to that fear or discomfort without engaging in the avoidance, the peak distress decreases. Waiting for this to catch up. Although competing responses are not part of the habit reversal training treatment, for body-focused repetitive behaviors, they also have utility in treating other repetitive behaviors. For instance, they can be useful in tolerating not just right feelings in OCD that have more of that somatic manifestation. While our goal is to have individuals with OCD feel confident in tolerating discomfort, we sometimes need to start by having them engage in a different task at the same time, serving as a competing response just to get them through that wave of distress. So we might start with something motivating for them, like a game, and work up to tolerating that discomfort without any distraction until it's no longer interfering, and ultimately have them be able to notice the discomfort that pops up but continue functioning with what they're doing. So in other words, using competing responses can serve as stepping stones towards ultimately sitting with and tolerating the presence of that discomfort. As I mentioned before, when we have a patient who has symptoms of multiple disorders, we can use that to our advantage as clinicians because it gives us more avenues to treatment. As an example, let's consider a child who has a disgust reaction to stickers. Stickers that create this reaction run the gamut from the stickers that teachers put on graded assignments to the stickers on fruit and to warning stickers that you find on appliances. So this individual also has co-occurring autism spectrum disorder that keeps the disgust reaction particularly stuck in their mind. Treatment would involve introducing him to stickers that make him feel increasingly disgusted and having him tolerate and continue functioning despite that disgust. However, some exposures might elicit too much disgust for him to manage, and so implementing a competing response during the exposures can help him to tolerate the discomfort. In other words, maybe we'd sit with stickers on our skin and play a game. And he would still be successfully tolerating the discomfort without ripping the sticker off and avoiding it. But his attention is not fully on the sticker itself, although they certainly, if you have this disgust reaction, are paying attention to it the whole time. With repeated exposures, though, we can then start to fade out this competing response, maybe waiting 10 seconds to start our game, or maybe waiting 30 seconds before starting the game to get to the point where he's able to tolerate the discomfort without a competing response. And this second example to show the benefits of considering an increased number of approaches that can be taken to treating symptoms that cross diagnostic categories, I want to consider a child who has fears that grab onto different aspects of his environment. So if someone mentions storms, he wants to avoid storms. If someone mentions gum disease, he wants to engage in reassurance seeking to make sure he doesn't get gum disease. His predominant fears, though, involve that are interfering with his life involve Lyme disease and robbers coming to harm him at night. So to prevent the catastrophic fear of Lyme disease, he avoids going certain places and he fears anything like hole punches or pieces of lint that look like a tick. To prevent robbers from causing harm to him, he keeps the door open at night to his bedroom so he can make sure to hear any noises, and he checks around his room repeatedly each time he enters. Diagnostically, the frequent shifting of anxieties looks like generalized anxiety, but he engages in some checking and reassurance seeking that gives it an OCD flair. Effective treatment, therefore, could incorporate multiple strategies. We could incorporate cognitive strategies to challenge some of the thoughts. We could expose him to his fears, and we could also mix this with response prevention to ensure that he's not engaging in any safety behaviors. Across treatment of multiple repetitive behaviors is another common thread of function-based analyses, which helps to increase understanding of what environmental factors may precipitate the repetitive behavior, as well as any consequences that could occur after the behavior. Through this come treatment principles that cross diagnoses. The first is creating a neutral environment. This is part of the tic treatment protocol so that kids are neither reinforced nor punished for engaging with tics. However, in treatments for anxiety and OCD, it also warrants parents understanding their kids' biological vulnerabilities and not faulting their kids for being afraid of something, and at the same time not letting the anxieties rule them, but instead taking a more neutral and guiding approach to helping them face their fears. Second is reduction of accommodation. So naturally, parents want to protect their kids from discomfort. This can lead to accommodations, though, like maybe taking a child to school if the child doesn't want to separate at home, and in a way that could prevent conflict at home, which could be aversive to the family. And these accommodations do allow anxiety to build its power, though, and often anxiety and OCD begin to require even further accommodations afterwards until it really starts to take hold of the family life. Third is reduction of reinforcement. Whether it's parents running to provide comfort to the kids who are ticking, or nurses who are so wonderful at comforting children who are feeling sick. But if it's because of anxiety, some of these natural inclinations can actually perpetuate the behaviors. And so we want to work to reduce these actions that strengthen the power of the repetitive behaviors. Taken together, as you can see that I just went through, there are a number of common threads to these to treatment of these disorders. So where does this get us? The commonalities and the advances in research are moving us in a direction considering mental illnesses not merely as falling into diagnostic categories, but thinking about the brain-based mechanisms that might account for multiple diagnoses. And this is important in improving clarity of what's going on for individuals who might not fall clearly into a diagnostic category or have more than one disorder diagnosis, and also to move us more towards precise treatments. Second, understanding commonalities in the reinforcement models can help clinicians to make treatments complementary and to make explanations more simple. Often a key piece that we want to help patients really internalize is to lean into discomfort, whether it's discomfort with urges to tic or urges to engage in a compulsion or separation anxiety. We want them to lean into the thing that is uncomfortable for them. And there's that underlying difficulty tolerating discomfort that we just don't want to fear or avoid. Third, research is looking into how we can better treat these diagnoses using what we know about common threads that run across them. I gave a couple of examples that of the increased options and flexibility that we have by understanding common threads in the disorders. And I want to tell you too that there is already movement in the field towards treatments to target some of these common diagnostic threads. Unfortunately, it's in other disorders right now and hasn't yet gotten to repetitive behaviors. But one of these is the Unified Protocol for the Transdiagnostic Treatment of Emotional Disorders, which is coming out of researchers at Boston University and the University of Miami that target exposures to core emotions that cross into anxiety and depression and other emotional disorders. Also, John Weiss at Harvard is working on a more modular-based approach to treatment to make treatments more effective at treating a child's symptoms rather than going through full protocols. Based on what I've presented, I do have some tips for parents. So first of all, I hope that understanding the relationships among these disorders eases your mind somewhat. A possible new diagnosis might not be as different as it feels if your child already meets criteria for another anxiety-related or repetitive behavior. Multiple diagnoses also don't necessarily mean that your child needs a full treatment package for each of the disorders. Second, I want you to take away some of the benefits of the commonalities of the reinforcement cycles and treatment approaches. One of these is that we want to help guide our children to lean into their discomforts. We want to help them do the thing that they're afraid to do, tolerate a sensory discomfort that they don't feel like they can, sit with an urge or attention even if they feel like they really need to tic. But of course, there are gradual steps to doing this. So one piece of advice that I'd offer to parents when their child says, I can't, is to ask, what can you do? What piece of this can you take on? Because truly, any effort towards facing discomforts is huge, and a piece of the discomfort might be all that they can handle in the moment. If the discomfort is too strong too, another piece of advice is that we can offer them some kind of competing response, somewhere else to put their attention as they face their fear. Ultimately, we'd want to fade out these competing responses, but these are important stepping stones towards ultimately carrying on doing homework or walking to school on their own despite the discomfort. I added these pictures to clarify the generalization of leaning into discomfort symptoms too. So if symptoms even within the same child manifest as difficulty separating or discomfort with germs leading to compulsions like hand washing or physical urges to tic, the same term of leading into discomfort is applicable. And note that I'm not saying to jump in, but rather we want to find gradual ways to lean into it. And again, competing responses can be helpful for doing so, ultimately leading up to being able to focus attention where they need to, like homework despite that discomfort. For educators and clinicians and providers, some helpful hints that I can offer are first, to calm the family's fears during diagnostic evaluations by explaining some of these relationships among disorders. Diagnoses can be overwhelming, and a few minutes of time can make a world of difference in a family's ability to understand and process the disorders that you diagnosed. Second, particularly when working with kids, it's useful to consolidate lots of technical language to increase how accessible it is to them and also how generalizable. For instance, if a patient has already been treated for tics and is now facing OCD, suggesting use of a competing response to tolerate that discomfort could be helpful, even though the term competing response isn't part of the exposure response prevention protocol. Third, it's crucial to generalize concepts that are taught. So if we want to target only the symptoms now, we're not getting at the root of the problem, thinking about those common diagnostic threads. Often we say that OCD symptoms not only come through the door, but they also find ways through windows or unexpected ways in. And we want to prepare individuals for other situations in which these repetitive behaviors could occur. So really having that principle of leaning into discomfort sink in and helping to generalize it throughout their life is important. One way of doing this that I use is creating Mad Libs to help them generalize concepts and ensure that they're ready to apply these principles in various situations. Fourth, understanding the common threads across treatments gives us more ways to be able to help these patients. And related to this, based on what I talked about in the presentation, it's particularly important to consider how disorders, how we can use the disorders that we know information about to inform treatments for autism and other treatments that are still being developed. So how can stimulus control or these prevention techniques and competing response strategies be used to help decrease interference of some of the repetitive behavior seen in autism? And how can we use cognitive work and exposures to help increase cognitive flexibility and use exposures to help increase functioning despite sensory sensitivities with autism? So this will be especially important to incorporate. In sum, I want you to take away from this presentation that the field is making an effort to shift away from thinking completely in a categorical mindset to working to understand relationships among these presentations. And as you can see, there are a number of common threads across these repetitive behaviors, diagnostically, in terms of reinforcement patterns, and in terms of treatment. And by understanding these threads, we can generalize treatment principles, apply principles more flexibly, and importantly, keep moving the field forward in terms of increasing the precision of treatments for each individual with their own unique set of repetitive behaviors and other symptoms. I want to thank you, thank the New Jersey Center for Tourette Syndrome for having me and hosting this wonderful program of Wednesday webinars. I've included the information for our clinic here, which is part of the University of Pennsylvania in Philadelphia, and you're welcome to find us online for more information. Thank you.
Dr. Roberts, thank you. That was a really excellent presentation. So I'm going to launch into some questions that we have right off the bat, and one of them is, you mentioned the Mad Libs, and I have a request that, could we see an example of that? So I'm not quite sure, you don't have it prepared or anything, but is that something maybe you could share a link to, or?
I would be glad to share that if we can figure out a way to do that. I don't have it on this computer with me right now, but we can certainly, hopefully, Marty, work together to find a way to share that with everyone. Okay, excellent. I'll leave it with that, and we'll call on a technical guru, Kelly, to work with you on how to make that happen. Okay. So I have a question about a 14-year-old has some Tourettic OCD and generalized anxiety. But what the situation here is that there is what's being described as repetitive, loud vocal tics, screaming, basically, during school. And it seems that the motor tics and quieter sounds are manageable, but the screaming is overwhelming. And they've tried various distractions, deep breaths, or replacement things like squeezing, I don't know if it's, well, it says squeezing fists, but maybe squeezing those ball things. But this mom would appreciate your comments on that. Yeah, I mean, that's a very good question. And really, it becomes a collaborative effort between the clinician and the family and the patient to really work through different ways to address some of those interfering behaviors. And sometimes one competing response can be effective for one kind of tic, and sometimes a different competing response can be effective for a different kind of tic. And there's no quick answer to that one, but it really is a collaborative process of working through what different competing responses there could be. And also, as I mentioned with the tics, a lot of the treatment involves any precipitants, that environmental factors that could be increasing the likelihood of that to happen, and trying to work to implement any kind of prevention strategies that we can to decrease the interference of that behavior. So if we know at certain points that behavior would be coming out, maybe there's something that we can do to help as a stimulus control technique in that situation. Certainly we can't be taking them out of class all the time, but we have had some children at our clinic for a period of time go to a different room and watch the class and until we can get the behavior under control, because I know it's not only interfering and hard for the child in the class.
Okay, fair enough. And I can realize it's kind of hard to address in this particular situation, but it certainly is a difficult situation to be in school.
Oh, absolutely. No,
yeah.
Absolutely.
I have a question from someone who commented that they noticed that you didn't discuss any type of medications to assist with these OCD behaviors and anxiety. So they're questioning why not?
Just outside of the scope of this talk, I know I'm already running over an hour, and so I really wasn't going into that. As a psychologist too, medication is also not my wheelhouse as much, and I think
Absolutely.
someone else would better speak to that.
Okay, understood. So we have a child who's heading off to college in the fall, living on campus that's away from home, so not local to home, who has trichotillomania. And they're asking for any recommendations regarding how to handle this in notifying the school. Is that something the parent should do? Is that something the student should do, or should they do it together?
You know, it would be important to notify the school of that, and there are different ways, that each school handles it. So I would look into what the counseling centers can provide for you, and a lot of times they have spelled out what they need in case the child needs accommodations of any sort, or counseling services. So I would go to the school's website to see the specific protocol for that, as that's what we typically follow as clinicians to inform the school.
Okay, and it would be the wise thing to do, I would suspect.
Yeah. If they're looking for accommodations, that would be a helpful thing for them to do.
Okay. Would CBT for anxiety work as well for an adult as for a child or adolescent?
Absolutely. Absolutely. I will say that oftentimes we see even increased success with cognitive behavioral therapy in adults just because they're motivated to work on the treatment principles. With the kids that come in here, oftentimes it's the parents bringing them in, and the kids don't have the same motivation, but adults often see the way that it's interfering in their life already, and it really truly is an effective treatment if you're able to engage with the exposure principles of facing fears.
Okay. Remuneration. So the question is that like being occasionally kept awake at night with things you can't stop thinking about? Is that the same thing, or is that something different?
I'm not familiar with that. Do you know?
All right, that's fine. That's fine.
Okay.
You talked about invariance, and couldn't that just be stubbornness? Like, when does it cross the line into being kind of inflexible?
Right, yeah, and it's a really good point, and I think this presentation specifically talks about how each of these pieces can be seen on a continuum, and invariance is even one of those things, and there are many reasons that someone also can be invariant. So there is a whole range from typical to atypical and invariant, and we want to, what I think we're thinking about with determining if a repetitive behavior is invariant is looking at the combination of those other pieces as well. So do they have the repetition? Is there that rigidity? Is there the certain way that it needs to be done? But, you know, I think everyone has their certain things that they like to be certain ways. And it's really just when it starts to become interfering and inappropriate that we really need to reach out and help these kids.
So that would be at any age then?
At any age, yeah, not just kids, you're right.
Yeah, okay. All right, we've gone well over. I'm going to ask one more question and then we'll wrap it up. It has to do with anxiety. So everybody experiences anxiety at some level in their lives. What is it about it? When does it cross the line into something that needs treatment and that's something that happens normally? Is that, again, maybe falling into the same category of when it becomes, you know, when it gets in the way? Let me say it that way.
Yeah, you're absolutely right, and that's such a good question. Everyone experiences anxiety, and we even start our treatments by talking about why anxiety is useful and why people do have anxiety. It keeps us safe. I mean, we wouldn't walk across the street without looking if we didn't have some kind of anxiety about fears that could happen, fears of what could happen. But you're exactly right that it's where it crosses into the point of starting to interfere in the person's life, that maybe they're avoiding certain things or they're missing out on opportunities that deep down they might want to take, but they're afraid to do that because something's getting in the way. So it's really, truly the point that the anxiety begins to interfere and keep them from doing things that they want to be doing that we would recommend treatment.
Okay. All right, then I am going to wrap it up here and turn it back over to Kelly to finish her piece. And I want to thank you, Dr. Roberts. That was a great presentation. Much appreciated.
You're most welcome. Thank you for having me.
Thank you for joining our webinar on how anxiety and repetitive behaviors interact to complicate a child's life. There is an exit survey which we need everyone attending to fill out. The webinar blog is open and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archive recording of tonight's webinar will be posted to the site. Our next presentation, The Relationship Between Tourette Syndrome and Autism, will be presented by Dr. Roger Kurland and is scheduled for September 26, 2018. This ends tonight's webinar. Thank you, Dr. Roberts, for your presentation, and thank you, everyone, for attending. Good night.